Welcome, friends, colleagues, students, citizens of the world. It's your boy, Leroy Horton, coming back to you one more time, an exciting time for me for another episode of the Teach Me Implants podcast. And I'm excited because I got my good friend from the other side of the country, Dr. Aierress Davis, back officially a periodontist.
Look at God. Won't he do it? Won't he do it?
And tell us, anyone that watched The Tooth Be Told, we had a very popular conversation a while back with some quotes that have made it into the parlance of my house. The no shade to her, but all the shade to her line. We've been cracking up and we use that all the time in my house now.
I love it. I love it.
How you been?
I've been good. Honestly, I am freed from the shackles of residency. But, with the new levels comes new devils. So being a new periodontist, there's still so much to learn. I think just being aware of that is half the battle. But I enjoy what I do. I'm very grateful for the time committed, although it felt like a ton of time. It did go by. So it's well worth it. I enjoy what I do, and I'm just blessed to be where I am.
Now, there's levels to this because, like, my students right now, they're feeling the fire hose that is dental school, right? You come from undergrad, you're like, oh, I'm smart because I got a whatever GPA. And you get into dental school, and before you know it, you drowning, right?
Right.
So I'm assuming you experienced something similar to that at that transition.
Definitely. I got a master's before I started dental school, which I feel like it kind of helped the flood a little bit for like the first 3 months. But then after that, it's like you're learning a new concept, dentistry, especially in dental school, it goes from didactic to clinical. So you have to apply what you're learning at the same time. So it's a challenge for sure. But I feel like with every level you get out and you are like confident and ready to go, and then you go into residency. And for me, residency was harder than dental school, to be honest.
Okay.
So I felt like I was in a foreign land. I always tell people I feel like I was dropped off in China and people were just speaking to me in Chinese like I'm just supposed to understand it, because perio is its own language. So foundational, it has a very long history. You have to understand the context of that history to realize how certain procedures and things come about today. So it took me some adjusting to do in residency. But like I said, with new levels comes new devils. But when I look back, I realized like I had what I needed in me to get through all these phases, and I did.
And you did that not just solo. I mean, you've got a son, you got a family. What's it like going through something that rigorous and trying to balance, spending time with your husband, reading bedtime stories to your son, or were you reading classic literature to your son?
Oh yeah, there was no lit reading in my house once I got home. Like once I clocked into my second job, which is being a mom, like my son would literally close my laptop for if I'm reading a, article. But I just kind of got up early. So my son really made me a morning person. So I would get up early in the morning. If it was things that I need to read, I would really make use of my time at residency. So I always told them when I'm working, I'm at work, but when I'm not working, I'm not at work. Like I'm leaving, So, but yeah, I would say my family is really what helped get me through. Just having that support system, like getting on the phone with my mom on the way to dental school, residency, crying, venting to her, talking about my challenges, and just having that that grounding of family and support, and my husband and all the things that have been through me with every journey, literally. So it's a balance. It's challenging, but it's doable. Yeah.
Yeah, and I think, shout out to all the spouses out there because, my wife was instrumental as my support system along with my mom and my mother-in-law. And especially when you got little ones, they do really have to step up for, that 3 years plus the 4 years of dental school, which can be pretty
Right.
consuming. And so what did it feel like that transition from I'm in residency, I can't wait to get out because I'll be free, this immense, this land of opportunity and freedom that you're envisioning the moment you graduate. And then you get reality. Was reality what you thought it was going to be post-graduation? What was that like for you?
Oh man. So I remember I had a dental school teacher tell me, because the first and second year floor was, I think, like the sixth floor of the building or the top floor. And he would tell us that once you leave this floor, you leave ideal behind. Like, as in ideal class 1 preps and this, that, and the third. When you go into the clinic and you see real people and real mouths and real clinical situations, nothing is typically ideal. And I felt the same way about residency. In residency, my program was very like by the book about things, they were very extreme, like if an implant's too deep and yada yada and all those things, which I think is great to learn and have that good solid foundation of what things should be. But then I get out there in private practice, and even in the first month or so, I see all kind of interesting implants and, having conversations with patients who have active disease and like, but they've been getting maintenance for years and they think they're fine, but it's like, hey, we need to kind of revisit this area. Of course, like staging and grading and like working with doctors that haven't adapted that new classification, which isn't super new. It's been like, however many years now, almost a decade, a couple of
Yeah.
years. So it's just so many things to manage in the real world, like outside of the scope of the academic setting.
Mhm.
And just understanding how to communicate that to patients without seeming like, you're arrogant, without kind of meeting them where they are. Cause that's how I've always liked to practice, is to meet patients where they are. I don't have to give you all this dental jargon. Like I know it, I understand it well, but patients just want to know like what needs to be done. Right.
Yeah.
So it's definitely a very delicate dance, but I enjoy it. Honestly, anything's better than residency to me at this point. So I'll take any challenge ahead as long as I can like have that freedom to do so. So yeah.
Right, right. And speaking of freedom, I've always been the type of person where if I have something looming ahead of me, I can't really relax fully. And you had written boards looming ahead of you, you had graduation requirements looming ahead of you, but you still got your oral boards looming ahead of you.
Right.
Yes. What are your thoughts? What are you doing to prepare for that? Are you even thinking that right now? Like, what is oral boards doing to your daily existence right
Oh my gosh. Of course I'm thinking about it. Anybody who knows me, everyone's always like, oh, Aierress, you're gonna pass. Don't worry about it. But I like freak out. I'm like the slowest person in the world when it comes to that kind of stuff. But I did give myself like this summer after graduation to get settled and acclimated. But I'm gonna start having like monthly refreshers. Cause even now, even just 2 months out, it's like, dang, what's that author's name? What's that article? Like when you're not in it routinely, and I was a huge lit girl. Like even my
now?
co-residents, they know like, Aierress, what was that paper about? Yada yada. And they can tell me. I'm like a walking library. But when you don't use it, you lose it. So I'm like, I can't be losing it this early. So I'm gonna try to have like at least to the end of the year, kind of like at least monthly to bi-weekly sessions for me just to kind of stay on top of things, which I still do now. Like, if I have a case, I'll pull up an article and be like, what was that article about? So and so. I have my little library from residency I took out of my resident room office and put it by my desk so I can like go through the files. So yeah, it's on my mind. It's in the back of my mind, but it's like whispering to me like, girl, you have to be ready. And I will, because I love talking about perio. What I love about perio a lot is that you have to, like, what does the literature say? You have to have a backing and a reasoning of why you're doing things. You can't just say, oh, I want to place this implant here because it looks good. Like you need to understand why and why you want to use this material to augment it and yada yada. And I really respect that because I think that it brings clarity to you as the clinician, but also the patient. I think I'll do well, or boards, hopefully, prayerfully.
Oh, you will.
But we'll see what happens.
You will. Now, for my students that might be listening to this, can you tell them when they hear classic literature, because right now they think they've got a lot, right? They're
Yeah.
like, oh, dental school, this is a lot. They do. I think I've probably already explained my experience with classic literature and the sheer volume. What was the structure of your guys' lit sessions? How many papers per session? How were you tested on it? What did that look like?
So I'd say in comparison to like my colleagues that have done residency was kind of lax a little bit. Like I would say on average, it depends on the attending, right? So some attendings are going to give you 20 papers regardless, doesn't matter, right? Others care about quality, so they'll give you certain papers. And it was really a discussion amongst the table. We would review the articles. We weren't really tested on it, but we did have set articles every week, and we pretty much did it year round except the summer.
Mm.
I know some programs only do classic literature in the first year and things like that, but like we had classic and current literature every year throughout the entirety of the year. We also had contemporary literature where we would make presentations about certain topics. Like I did amnion chorion membranes one year, things like that. So,
Okay.
but for me, it was really hard because in my mind, when I think classic, I think like 1800s or something, like old papers, people who aren't living. And then when I went to AAP and they were like, oh, there's Dr. Boozer and this and that. And I'm like, oh my
Mhm.
God, these perio celebrities. But classic literature are like articles that made a difference, articles that kind of set the standard, like experimental gingivitis in man and things like that, that were like,
Mhm.
even though that is an older article, obviously, but they're classic in the sense that like they changed the narrative of dentistry, right? They're things we can still address to this day. And then some things are classic and like we don't do that anymore. But because we did, the modified Whitman flap in this certain way, now we consider this when we do flaps for surgery. So For classic literature, they're like foundational papers that really impact not just periodontists, but our profession as a whole.
Right. And my students I'm already giving them a dose of classic lit. So each week I have a lecture on Thursdays.
Okay.
And each week there's a classic literature paper that coincides with the topics we're talking or reading about in the textbook. And there's an online quiz that they can take from home. It's open note. And the papers are very easy papers, like Gargiulo. Right? It's 6 or 7 pages, very simple, straightforward. But it's introducing the literature, like, hey, this is how we know what we know.
Right.
And it's not just true because you read it in a textbook. Like, these are the experiments, this is the science that validates what we're teaching you. And I'm really big on that. And my program was a bit more heavy in classic lit. We had about 40 papers each week.
Wow.
And we would have to read them all. We have to read them all. And then amongst the 9 residents, we divide them up and we do written summaries for our respective ones. We'd present on them, like we'd all read our summaries and discuss them. And then every 4 weeks, we would have a closed note essay exam. It'd be 6, 7 questions, and we'd have 3+ hours. And in those, you have to answer the question, cite the literature, at least cite the content, and if you could, cite the author and the year. And it was bananas. The way my students now feel like what they're being asked of is impossible. That's where I was first 6 months of residency. I was like, there's no way anyone remembers this shit at all. And then guess what? You do, because they are so foundational. They come up all the time. And to be honest, especially if you're looking back in the 60s to the 80s, it was only a handful of authors that really made the most significant contributions. So their names came up. So chances are, if you drop the name Greenstein,
right,
it's probably going to pertain to something on any topic you're talking about.
Yeah.
Okay, but you're in practice now. And are you doing the types of cases you thought that you'd be doing right off the bat, or is it still a slow build like beginning of residency was?
Because I knew that the practice I was going into, I was going to kind of fulfill a purpose there, especially with implant placement. So I have been able to attract those type of patients. Well, not attract, but treatment plan in those cases. One thing I would say is I practiced in Buckhead, which is the fancy schmancy part of Atlanta. And people assume that there's not a lot of disease in that kind of space, but there is. So I'm really happy to still treatment plan periodontal disease, talk about different approaches and ways to address and stabilize, periodontal disease. Some things though that I am kind of struggling with, which might be across the board, is soft tissue cases. So I've diagnosed a lot of recession. I've diagnosed a lot of aberrant frenum pulls and things like that. But kind of getting that over the actual treatment and people seeing, unless it hurts or it's painful or it's an aesthetic compromise for patients, then they're like, okay, let's do something. But kind of in its early stages where I'm like, hey, some people have thick tissue, some people have thin, having that conversation. Right now I'm kind of modifying habits, like brushing and staying on top of, oral hygiene. But I'm hopeful to kind of get more people to understand the importance of quality tissue and addressing recession sooner rather than later. So that's been kind of a struggle area. But again, I've only been there for a couple of months. So
right. Are you running into the experience of a general dentist referring for something, and then there's 10 other things that they refer for an implant, right? But then there's uncontrolled perio. How have you learned to politic that situation where you got to call back the dentist and say, hey, I know you mentioned this, and there was no mention of all this laundry list of stuff that's going on.
Right.
How do you talk to your general dentist about proper sequencing and that kind of stuff?
So I've only had that a couple of cases. One case in particular, a general dentist was referring for crown lengthening. They would not send other x-rays. They only wanted to send that one x-ray. And they were like, that's all I want you to look at is just that. Don't do a comprehensive exam. And for me, I'm all about boundaries. Okay. So you cannot dictate what happens in this practice. I can't tell anyone else how to practice in their practice, right? And for me, obviously, I have to feed my family, but I'm not super money driven. I want to have quality referrals, that understand our dynamic and work well together. And if that's just a referral that we don't work well together, you could find a periodontist. We could tell them not to do a comprehensive perio exam, just look at one area. But unfortunately, I'm not the periodontist for that. So, that patient just never showed up, and that's okay. Other patients showed up. But I feel like I navigate that as well by sending very detailed letters. I feel like I've gotten really good responses from my letters. So I'll put like, the patient's chief complaint. I'll just refer for evaluation for implant placement number, whatever. And under clinical findings, I'm very detailed in what I see. So I'll be like, generalized bleeding on probing, treatment plans includes, and I'll give multiple treatment options. So like a lot of GPs want to alternate cleanings, to kind of still keep their income. That's fine. Like I try to kind of cater to those recommendations, give my personal information, let them reach out if they have any questions. And that seems to be pretty well thus far. But I think you just have to, I don't know, I feel like because I didn't go straight into residency after dental school, and also I wasn't like super young when I graduated dental school. I wasn't super old either, but I just feel like I was very like sure in myself that no one's gonna bully me about like how I practice, because like
Right.
I practice, but also I know how to do it in like a professional way. That's not like, we're doing what we want to do here, but like, hey, let's have we're healthcare providers, we have to work together. I understand you want an implant. And I also get the patients to understand that, right? Because people think, oh, implant, great solution, yay. But I'm like, if that bacteria touches my implant, the implant isn't as durable as the tooth. And when things start happening there and you've invested all this money, then, we want to make sure you're stable before we move forward with implants. And usually when I put it in that way, patients are like, yeah, that makes sense to me.
Right. Now, I think that's a great segue, because the inspiration for this particular episode came from questions that I had from my students, and then questions that I had from a good friend of mine that listens to the podcast. And you know how it is when you're the one dentist in a friend group, you get all the oral health questions, right? They see a compelling YouTube video and they're like, "Hey, should I get all my root canals taken out?" Right? Or hey, so my students one day, we were talking in class, and I was just kind of gauging what their knowledge of perio was. And I asked them, what is periodontal disease? And, hands went up and they started describing, inflammation, bleeding, swelling, bone loss, and so forth. And maybe about a fourth of my students are previous hygienists that have a bachelor's in hygiene. So they tend to be a little bit more on these questions than the non-hygienist group. And then when I asked them, well, what causes this destruction? Almost everybody said bacteria causes it. I was like, okay, let's roll with this. Let me see if I can fish out some more information. So there was this predominant notion that the bacteria directly cause the destruction, and that if we know what these bacteria are, we could potentially target these bacteria. So what would you say to that particular answer, that periodontal disease is caused directly by bacteria?
I would say that periodontal disease is a multifactorial disease, right? That some people can have bacteria that are implicated in periodontal disease and not have periodontal disease, right? You can do a swab of one patient that has clear bone loss, clinical attachment loss, etc., and another, they both can have Porphyromonas gingivalis or all of our red complex bacteria, which I won't go too deep into. But why is it that in some patients that have it, they develop periodontal disease? I think that deals with the host response quite a bit, right? So we have to look at the person. And that's why when you see things like our new staging and grading system, and we consider social habits like smoking, we consider autoimmune considerations like diabetics and wound healing potential and things like that. All of that plays a factor in a role in periodontal disease. So is bacteria important? Is it significant to periodontal disease and the pathogenesis of it? Yes, absolutely. But is it the sole reason that periodontal disease happens? I would say no.
Okay, so I'm gonna share the screen with you, and I hope I don't give you any
PTSD.
flashbacks and PTSD. Let's see here. Let me know if this plays on your end here.
Oh, yeah.
Okay, so back to the days of Sokransky, and this will leave the screen in a little bit. But the bottom of this pyramid, we have bacteria that are predominant commensal bacteria. As disease tends to progress, we see a shift in proportionality. So we might see more of these PG, denticola bacteria to be not just present out of nowhere, but just in higher proportions, right? And so I can see why your lay person or even your lay dentist might look at that and be like, oh, okay, there's a direct correlation between this bacteria and there's a linear relation between that bacteria and periodontal disease. But it's not that simple, like you said. It's a multifactorial progression of disease that, I guess the other question I guess I would have is periodontal disease linear? Like, do we see destruction evenly over time, or what does the time span or the lifespan of periodontal disease on an untreated patient typically look like?
Right. So it's definitely not linear. With periodontal disease, you can see like intermittent bursts or exacerbations of disease. Don't get me to talking about the author and article, okay? I know. Give me some time to get in my. I'm just kidding, but
Right.
no. It's definitely not linear. Which is a big reason why we push maintenance and compliance with maintenances and things like that, right? But no, it's not that you see the destruction immediately, and over time, a lot of longitudinal studies have shown compliers and non-compliers and the amount of tooth loss that they experience. And believe it or not, and some of those non-compliers, like they didn't just completely become edentulous over time and all their teeth fell out. But of course, when you're non-compliant, you don't show improvement and stability as someone who is compliant with the maintenance and things like that. So it's definitely not linear. Obviously, like, why would we be doing this if it was so predictable? And I know, like, okay, I have to swab you have this disease, I just clean you really good, and then it's cured, perfect. Like, we would be out of a job, right? Because periodontal disease is so unique in the way that it manifests, and it's really host specific. And even down to the host, it's like what's happening under that gum line. Is that environment becoming more anaerobic, and is calculus and different factors playing a role in what's going on in that periodontal pocket as a whole. So it's very, very complex.
Very
Not
complex.
linear.
No pun intended with complex of
Right.
the bacteria. No. Okay. Okay, perfect. So this is, again, from Sokransky articles where they group the different types of bacteria that tend to be present in their proportions in health, in periodontitis, in elderly patients, in refractory disease, which means disease that has been treated and for whatever reason it's kind of reactivated. Right.
Mhm.
And what you see is that, and going back to this notion of, well, if we know what bacteria are present, that can dictate our treatment.
Right.
A lot of this bacteria is present even when you're healthy. So if we were to do a test and we're looking at the existence of, let's say, Porphyromonas gingivalis, which is a notorious periodontal bug. If someone came to you and they had 3 to 4 millimeter proteins, and you did a salivary test because some offices do it on everybody, right? And it shows, hey, they've got a higher than normal proportion of Porphyromonas gingivalis. Would you do anything different in that real time if the clinical parameters were not?
No, I would not.
Okay. Why do you see so many offices where, and I'll stop sharing here. Why do you think you see so many offices where everyone that comes in gets this cookie cutter response? I'm seeing offices where everyone that comes in gets salivary testing, gets CBCT, even if it's general dentist, there's a lot of holistic offices here where everybody gets a CBCT. Is there a value to having this barrage of tests for everybody?
I would say no, but with the caveat, I think that with dentistry, things can become so like new things are popularized and stuff like that. And it's also financial components to it as well, but we won't delve too deep into that. But I think as far as salivary testing is concerned, some of the salivary tests that I've seen, I like when they report not only on the bacteria, but also like any viral components that may play a factor. And I think they're indicated in certain cases. So, for example, I had a patient who all of a sudden, she's a previous hygienist, believe it or not, but she started having pain and kind of blisters on her mouth. She mentioned her kids were sick before, and then she came in and had all these deep pockets and this bone loss. We were trying to figure out what happened. So this was before me, but my doctor did a salivary test on her, which not only tested for periodontal pathogens, but also viruses. And she tested positive for Epstein-Barr virus, which is typically found commonly in the depths of like periodontal pockets and things like that based off the literature. So it kind of coincided with that. And I felt like it was a good educational tool to not only show her why this was happening, what it was associated with, but it didn't necessarily change my treatment. We still put her through scaling and root planing and wanted to reevaluate and then kind of address those deeper pockets, see if there's any regenerative potential, things like that. But I think for like patient education, and some of these salivary tests give recommendations as far as like what prescriptions and medications, and they tie it to like cytokines sometimes to talk about inflammatory reactions and how it's tied to different diseases in the body. I think that's good for patient education, but every single patient needing something like that, I think is really an overkill, honestly. And it's useful when indicated. But for me, is it going to change my treatment? 10 times out of 10, no, because I can't create a magic bullet to go kill all the PG in your mouth. And upon doing that, will it give me the result that I wanted? Likely no. So I think new technology in dentistry has a role, but it's not something that's cookie cutter for everybody.
Right, right. And I agree with you. I'm glad that you said that. I think in the patient education realm, patient motivation,
Right.
it works great. It gives them more information. They feel maybe more, if the standard of care has just been probing x-rays and we talk to you and I go to an office and now they're doing something that seems above and beyond what the rest of the practitioners that I've been to are doing, it may give me a sense of maybe greater trust,
Right.
right? Like, oh, they're doing an extra level of testing, which I feel like that's, if you were to sell it to me as that, I would 100% buy into it. Like, yeah, it helps motivation, compliance. Where I get, a little bit on my high horse is when the representative comes in and says that this is the best way to dictate treatment, to decide treatment. I think we're in concordance on that. We're going to go off our clinical parameters,
Right.
right? Let me share the screen with you one more time
Okay.
because I am going to share my test results here.
Okay. Let's see. Need a full mouth extraction?
Right, right. Well, I'm coming to Buckhead if I do.
That's right. We are not taking out those teeth over here.
Let me know when this pops up for you here.
Okay. Yeah.
Okay, so this was my test. So this is one called Oral Genome that we got the kits for free, right?
Mm-hmm.
And what I was surprised is the salivary the testing component, you didn't have to send it off. Everything was, gave you the results in real time, and you downloaded an app and you kind of read the results off the colors that it gave you, the change in the little testing strips. And it really seemed to test for my salivary pH, the presence of the one bug, Porphyromonas gingivalis, and then the presence of MMP8, which is an enzyme that breaks down collagen and so forth. But everything else was a self-reported questionnaire. So as far as caries risk assessment, it was based off my answers to questions on the app. On gum disease, it was based off my questions. It was, do your gums bleed when you floss? Yes, no. How often do you go in for your cleanings, etc. The diabetes was, again, self-reported. Have you had your A1C? Have you had your blood sugar checked? Do you ever have, it listed a slew of symptoms? So all this was almost just self-reported other than the PG, Porphyromonas gingivalis, and the MMP8s. And so now I started thinking, and I'll stop sharing here. So my results essentially said I'm low risk for periodontal disease, but it was all self-reporting almost. Which in my head, I'm like, all right, well, if you're going to charge me for it, if I'm going to the dentist for this test, but it's really just like I could have gone online and there's a slew of websites where you do like self-health assessments and oral health assessments simply by answering questionnaires. What is the true value outside of, all right, do or do I don't have Porphyromonas gingivalis?
Right.
Right?
To say oral genome, you got to step it up. That's not it. I know you might not be able to say it, but that's not it. Oral genome, you're only testing for one bacteria. I don't like that. The test that I have experienced though, test for several, and you do have to send off the sample and get it back and wait and all that. So they're a little bit more in depth than that. No self-reported questions. It's literally just a swab and we send it off and they test for, what's available. But I do think, because also too, you mentioned trust and I wanted to go back to that. I feel like we're in an era where dentists, I think it's always been that way, but a lot of people don't trust dentists. Especially don't trust them now with things that are accessible on social media, and some random person trying to sell a product on TikTok shop is like, I brushed my teeth with this and now I don't need an extraction anymore. And they're just trying to get your money, right? So like it's good to kind of step away from our typical old fashioned way of just, I'm the doctor telling you this is what you need. Because unfortunately, a lot of people don't believe that anymore. So when you do something like a legitimate test that comes from a third party and you can show them like, hey, I know you don't believe me when I say I use this probe and you have deep pockets, but here's this test showing you, hey, this is what you have, this is why you have it, and kind of bringing the patient into the care team. Because I feel like nowadays people want to be more involved than before, where people just come and do like, okay, doc, whatever you say I need, I'll get, right? But if it's something that's self-reported, a lot of times patients don't even know. I can ask a patient, do your teeth bleed when you brush? And they could say, I don't know, right? Sometimes they allegedly brush their teeth every day. So, it's just, It's like to put the responsibility on the patient to answer certain like questions. Sometimes they don't know because they're not paying attention, or they know because they just don't know, right?
Right.
I mean, you and I, there's so many uncontrolled diabetics. You take a pre-surgery glucose reading and it's through the roof, and we're like,
Mhm.
are you taking anything? Uncontrolled hypertensive patients. So somebody gets asked about diabetes and they think, I'm fine, I feel fine, but they're
Right.
not. Then it's like, how accurate is that test when you're asking a self-reported question, you know?
You know, that is I love how you said that, because you're right. I'll have patients that I suspect might have diabetes. I always do a finger test in the
Mhm.
office. And I've caught so many patients who,
So many.
their fasting is like 180, 190 or so. And no, I had no idea. Same
Right.
thing with hypertension. I feel fine. Well, you're 190 over 105.
Literally.
You
Right.
know.
Walking around
Um,
like every day.
right, right.
Ser-
Right. And and this whole thing about social media. And I'll be honest, when I first got introduced to you was through your interview on, I think it was with Bridget White on the Black Dental Reserve, and it was like you had just gotten into residency and hadn't started yet, or were applying. And I was like, oh, she's got a compelling story. And then we ended up connecting over the years, and we talk and chat and stuff. And I'm old, so I'm not a big TikToker. I have a TikTok because my kids are like, you should probably have one. But I
Mhm.
really don't do. I'll just take the video that I put on IG, I'll
Yeah.
download it, and then I'll throw it on TikTok, right?
Yeah.
Just to have some type of presence. I'm not a big influencer whatsoever.
Yeah.
And I didn't realize you were on TikTok at some point.
Uh-huh.
Then all of a sudden I realize it, and I'm like, holy cow, she's got like tens of thousands of followers, right? And I was like, oh, that's dope. But I only realized it after I saw a video where it was your likeness being ripped off
Yes.
regarding one of those toothpastes that, like, if you got cavities, you just brush with this and your cavities are gone. What can you, to my students especially, who they're all influencers now, right? You know, come live a day in a life with me as a dental
That's
student,
right. I
right?
love
Which,
it in the life.
right,
Yes.
right. But there's a danger to that, right? Your likeness is there for the using. What happened? What were they doing with your likeness?
Oh
And
my
is that
God.
is that over with? What's
I
going on?
over with. I have spammed it every time I see it. I honestly have to probably just lawyer up and really take the time to get into that. But essentially, I made a video walking to Chick-fil-A in the middle of a day of residency. After talking to a patient who came in like the student clinic for a cleaning, right?
Mhm.
And he was just a period maintenance patient, but he might have had some deep pockets or something along those lines. But he made a comment saying, I just want to get all my teeth pulled out and go from there. And I told him, I'm like, trust me when I say your teeth, what you have now is much better than dentures. And a lot of patients are confused by that. They think instead of managing these dental problems, let me just take them all out. And you don't want to do that. That's what the video is about. Literally less than a minute. Didn't even get paid for it on TikTok. If you know, you know. Just walking to Chick-fil-A talking. The video goes viral ish. A lot of people comment on it and talk about, keeping teeth, dentures, and all that. And then all of a sudden, months later, some like random toothpaste product uses my name and puts AI over my mouth and is like, if you want to save your teeth, use it. And I'm like, whoa, 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 whoa. And I'm like, literally commenting on every page. People are tagging me in it, like, hey, just let you know they're using your face and all that. So I told TikTok about it. They said nothing was happening. Like they didn't decline it, which I'm not going to get into the politics of what TikTok allows and what they don't.
Mhm.
It's not, if you think that's bad with dentistry, don't even get into like politics, this is all that stuff. Like some things you'll see and some things you won't, but I'm still trying to fight it, basically to answer your question. But I don't know. I think that the reason that I got on TikTok so much is because TikTok is more casual than Instagram.
Mhm.
You kind of have to be put together and aesthetically pleasing on Instagram versus TikTok. You can just get on there and talk. And I realized there were so many voices of like veneer techs and people who literally have limited dental experience telling people you don't need this, you don't need that, and not actual people practicing, giving people resources to reference. And like that's rooted in fact and expertise. And that's really why I got on there to kind of combat that and be that resource. Like, quick story, when I started working, my doc, she introduces me to all the patients. So she brought me in the room for a post-op after crowning me. And she was like, oh, hey, this is Dr. Davis. And within 5 seconds, the girl was like, are you on TikTok? And I was like, yeah, I am. She's like, oh, I was looking up all these videos before I got this procedure and I saw some of your videos. And I'm like, that was my whole purpose. Like, yes, I enjoy cursing out a veneer tech or two for fun and whatever. But my purpose was to be like a legitimate voice in the midst of all these videos pumping out this information that isn't accurate about dentistry, which is my prized possession and profession that I'll take very seriously. So
And I'm happy you said that, because I think you're right. Now that I think about it, you do seem to have to be either for Instagram, you either have to be a lot more polished or in a bikini, right?
yep. Yeah.
Whereas in TikTok, I mean, I've got a couple people that I follow that are friends of mine for years, for decades, that they're super popular and they literally do rants from their bed in their bonnet.
Right. Literally.
Right.
Really, like TikTok is like the church say, come as you are. Like you can
Right.
just pop up, say something, and it's so crazy. The things that go viral on TikTok, it's not about me talking about gum disease and this is the best product. It's me clapping back at somebody that's trying to tell me how to do a treatment that I've spent decades learning how to do. So
Right.
it's really, you can't get too wrapped up in that. Like me having my followers and stuff, like I try not to get wrapped up in that. I try to just remember my why and where I want to go with this. But I really just want to be a legitimate voice about dental procedures, because you see so many things that look legitimate. Like a lot of these veneer techs, they look legitimate, like a real dental office. So when you see it as a layperson, you think, oh, I mean, this work looks good. Of course there's a doctor doing it, and it's not. It's not.
Right. Right.
Yeah.
And so, okay. I think this is probably the part that I've been waiting for, because as I've been texting you trying to set this up, I was like, hey, I got this perfect question that I need you to field in real time. I don't want to prep you for it, but I think we've laid the groundwork. We've laid the groundwork of bacteria, oral health, education, testing, and so forth. So I got this good friend of mine that actually, the episode that's the most current episode of this podcast is with her. She's an amazing project manager here in the Northwest. But she had this question for me that she had sent me via voice note. And I fell out, like I dropped my phone and fell out. And I was like, you know what? Please, 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 can you video record that question? Because I know who has to field this question on the air. So I'm going to play it. Let me know if you can hear the audio.
And I hope your family and you are well. As you can see, I am at the dentist because I have a cracked filling that has to be replaced. But I had a question. So I don't kiss men on first dates, and a lot of men have been upset about that. And the reason why is that I feel bacteria, if someone's mouth is not healthy, and if I kiss them, that bacteria could be transferred to my mouth. And as a single person, they're not obligated to me, right? Even if we're going on dates, until we establish something serious or official. So I tell them, like, you could have had your tongue in another woman's butt an hour before this date, so no thank you. And they're shocked, like, who says that? And so is that true? Can bacteria from one person's mouth transfer to another person's?
We can play it multiple times.
Okay.
Let's see here. Okay. Now, mind you, this friend of mine has sent me dental questions before.
Yeah.
None of them, and I'm sitting there listening. I'm like, okay. She's asking about bacteria and so forth. And this notion, I cannot get this visual out of my head now. And for anyone that, the audio wasn't good, she literally said if she goes on dates, she doesn't kiss men on the first date because they could have literally had their tongue in another girl's butt 20 minutes before the date.
Right.
And she don't want no parts of that. No parts of that.
And she's valid.
Now, how would you answer that? Because I've gotten some weird questions in a dental chair that, we could talk about later. But this, Miss Antoinette is in your chair and she asks you that question. How do you respond?
Say, you are very wise, my friend. Okay, don't kiss these yuck mouth men on the first date. Okay, ask them, do they floss once a day? Do they brush twice minimum? Okay, and even still be concerned. But I would say the concept that bacteria from one person's mouth is transmissible to another's is true. Yes, that can happen. Now, can that bacteria, when it goes to another person's mouth, become active to cause disease and things like that? I would say it's like, depends on the study. I can't recall off the top of my head any study where they've proven that bacteria from one person to the next person's mouth, as far as gum disease wise, has caused the person to develop gum disease. Now, cavities, like between mom and baby, you have those kind of studies where like strep mutans could be present, stuff like that. But I would say, like, if someone's going in someone's rear parts before they see you, yes, don't kiss them because, yeah, those things can happen. And I do have patients who, like, for example, they'll have like their husband who has gum disease and they'll say like, oh, well, I've been having kind of lower feminine issues. If he gets his oral stuff together, can that help me? And if you can kind of connect the dots for that without me getting too specific, I hope you can. But yeah, it's like bacteria is bacteria, you know. Can it get into the pockets that populated cause destruction in abundance? Yes, but typically not transferable from a person to person. But I would say her belief that I can't be kissing everybody because things can transfer, that's a very solid, firm belief that I think she should keep and keep near and dear to her heart, okay? But for it to like crack a feeling and stuff, no. But it's definitely something to be cognizant and aware of. Like, she ate with that one. People need to know. I'll tell my daughter that. That'll be a story I tell my daughter when she grows up one day.
You know, and I was actually thinking about that too. You know, when you talk to you know, because I got 2 daughters, they're all grown now, but you know, you give them horror stories. You know, like when they're a kid and you don't want them to have sex, so you show them all the pictures of STDs and stuff. You know, that'd be a great I guess warning. Like, listen, don't be kissing these nasty mouth little boys. You don't know where their mouth is.
Don't kiss them yuck mouth little boys and little girls too. I have a son, so I be telling the same thing. Don't watch your mouth. You know?
Right.
But yeah, oral hygiene and bacteria. Yes, there are studies where, you know, you've seen it in siblings and parents and things like that. And in partners, of course, as well. So it is something that is a valid concern that she should be concerned about.
So there is one study where they looked at couples in a periodontal office. And what they found is that there did seem to be some concordance in bacterial profiles when the patient of the office was a longtime patient with uncontrolled perio disease, and they brought the husband in or the wife in for testing. They tended to have to share greater bacterial profiles.
Right.
When the spouse also had higher incidence of disease. And so it wasn't so much necessarily that the certain bacteria caused both of them to have diseases. They probably both have similar patterns, right? If you don't brush, your partner is probably going to be someone that also doesn't brush and floss, because that's for that reason they can accept you, right? They both got perio breath, right? Which is another thing. So this friend actually was asking me, she's convinced she can smell cavities. So can you enlighten us on, when you can smell something in someone's mouth, what typically would that be?
Wow, that's a great question. And it's like, I actually saw a TikTok video about that and us being able to smell. It was not about cavities, but it was like if you haven't flossed, like there's an abundance of plaque. And sometimes you can't know a plaquey smell, right? In patients. Like obviously you and I, we have some grade A sniffers, okay? We endure a lot of different fragrances, you know, when it comes to the oral cavity. As it pertains to like smelling cavities specifically, it's, you know, sometimes you can note a different smell of like a tooth that's decaying, right? Or like, I don't know. I feel like perio breath and things like that, obviously like we are kind of around that area a lot, so we can pick up on certain things. And then sometimes people have gum disease and, you know, you don't smell anything per se, you know, or like just like people who have gum disease in deep pockets, but there's no bleeding. They may be heavy smokers, things like that. So things can mask different things, but as far as like smelling cavities, I won't doubt that. I never tell people what they believe they can do, they can do. Like you believe that, by all means. But yeah, I feel like, especially for us, we smell a lot of different things, so we can pick up on stuff pretty quickly.
So do you think there's validity in the smell your floss test?
What exactly are they saying? Like if you smell it, if it smells like something, that means what?
That you're not flossing. So I've seen this, you know, I'll be honest, I feel like there's probably some validity to it. They say if you want to know what your breath smells like, or if you have perio breath, floss your teeth and then smell that area, smell the floss that you just used. If it doesn't smell good to you, probably you should be flossing more often.
I think honestly, anything simple to get people to simply floss, I would agree with. You know, seriously, whatever I have to do to break it down for you to make a change. Yes, but I would agree with that. I feel like you can floss your teeth too, and it might smell that you floss routinely. But if it does smell significant, then it might be something going on. Probably, sure. I might need to do a study on that. You know, get it in literature or something.
Right. Make it classic. Make it classic.
Right.
So for my students, as we wrap this up, that are interested in perio, what guidance do you have for them? I mean, they're first years now. This is the inaugural class at PNWU, brand new dental school, first class, setting trends, creating history. But there's no pathway on site because there's no upperclassmen, there's no residency programs yet at the school. What guidance would you have for a student that, let's say I inspire them for perio these next 4 years and they want to follow on that track?
Man, I would say, first of all, expose yourself to all the aspects of dentistry that you can, right? For me, I always knew I was surgically inclined. I like the surgical aspect of dentistry a lot, but I didn't know like all of the different specialties that were available. I just knew about oral surgery, to be honest, like pre-dental Aierress. But then I did an externship, so that would be really great to like extern, connect with other pre-dents and stuff at different schools by being in organized dentistry. Like I was a big ADSTA girl, so I can go to other conferences and talk to people about what they're doing in their perio courses and, you know, things like that. But then when I did an externship at UAB, actually, I was like, wow, like this is what perio looks like now, like not what you're learning in classic literature, not what you're seeing used to be done or deep cleanings and long junction. Like perio is so, you know, it has evolved so much and it's a large scope of practice right now. So that intrigued me. And from there, I just kind of positioned myself, of course, focus on your didactics, focus on becoming a dentist, right? Because another misconception I had was like, oh, when you specialize, you don't have to worry about all those other things like root canals, endo, who cares? You know, I'm not doing any more crowns, whatever. But you have to, as a specialist, be a dentist first, right? So you need to understand and appreciate all aspects of dentistry and how you as a periodontist play a role in that. So don't ever get confused by, if you want, especially perio. I can't speak for anybody else, but for perio, you need to know ortho, endo, restorative, all that plays a factor and will for the remainder of your career. So I would say it's really exciting to be the inaugural class and like set the standard. But I would always tell, especially pre-dental and dental students, to give yourself grace on the journey. It is a journey and it's challenging, but you know, you'll always end up where you need to be. And my journey definitely is a testament to that.
That's awesome. Well, Dr. Aierress Davis, how can any of my students or anyone else listening to this find you, follow you, learn from you? What are the best ways to do that?
Yes, I am at Dr. Aierress Davis. That's AIER Davis. Pretty much on all platforms. I'm trying to make it seamless now that I'm like free from the shackles of residency. Okay. But yeah, you find me on TikTok, Instagram, YouTube. I do have some videos on YouTube, my early YouTube years, where I talked about like what's a periodontist and I kind of share specifics about my journey as well. And you can always just DM me, message me. I pretty much respond to everybody that says, hey, I want to be a periodontist. Can you help? Because I would love to see more periodontists of color, more Black women, and just in general, just feed into the specialty because it's a really great specialty and it serves a very important purpose in dentistry.
Right. Well, thank you. And thank you for giving us your time. I always get excited to be able to highlight not just experts in our field, in our industry, but especially experts that look like you and me, that are not just famous for having a social media platform, but are competent, knowledgeable, compassionate providers in the community. Because beyond this 2025 social media realm, being more of a purist myself, I tend to gravitate to people that, although they might have other things going on, their primary focus is their craft. And having been friends and following you for a while now, your dedication to your craft is top-notch, paralleled, and I applaud you for it. So thank you so much for giving me your time. So for everyone that has listened, please go follow and learn from Dr. Davis. And I'll leave you with my parting words as always. Keep reading, keep listening, keep learning, and we'll talk to you soon.